All right, it worked for everyone else, so I'm going to give it a shot. Good morning, everyone. All right, okay, I'm glad that I could get one too. All right, so I know that I am in the unenviable position of following Dr. Consuelo Wilkins for the second time at a major conference this year, and I'm also standing between you and maybe like a bio break. So I'm going to go through this very, very quickly. This is just a kind of a quick research update on some of the work that I've been doing with a DP1 that I was awarded in 2020 called the Forever Study. And so I'm going to give you just a partial update on some of the information there. I'm going to open and close my talk today with quotes from famous activists, civil rights activists, so just to kind of help remind and provide like a strong context for the work that we're doing. It is not enough to make iterative improvements. We really must make transformative improvements to try to really ensure that when we successfully treat Alzheimer's disease, we do it for everyone. So let's talk about our progress so far in trying to welcome minoritized individuals into our clinical trials. Now, this is the data from the phase 2 Trailblazer study that was just released. The data was just kind of published a few weeks ago. And I know that we've talked a lot about how much we've gotten better, how much we've improved, how far we've come in 5 years. I want you to look at these pie charts and ask yourselves, how far have we come in 5 years? Not far at all. What are the consequences of not being able to come far? Let's highlight a couple of the groups here. So these are the forest plots from that same set of studies from Trailblazer. It doesn't really matter what the outcome is because the data all look the same. But what you see here is when you break the data down by ethno-racial minorities, you see that for those of you who can't read forest plots, if you want something to be reliable, to know whether it works or not, you don't want it to cross that middle line. And so obviously you can see that those widest bars come from the smallest groups. So again, how far have we come? Now, what's interesting though is that it's not all minoritized groups that are poorly represented in these research studies. If you think about E4 carriers, we recognize that in the Trailblazer study, as well as most other clinical trials in Alzheimer's disease, we have upwards of 70% representation of individuals who have an E4 allele. You might ask yourselves, who has the most, the most significant presentation of E4 alleles? Well, by gosh, it's those same minoritized individuals that aren't represented in the studies at all. So it's clear that we as Alzheimer's researchers can get minorities to participate when we want them, even when they come from other groups, other populations, apart from the ones that we claim to care about. So again, let's think about how far we've come in 5 years, how far we've come as we march on towards trying to resolve Alzheimer's disease, not just for the most privileged, but for those who are at the most significant risk. So we've got work to do. Anybody who has heard me talk in the last 5 or 6 years has seen this slide. We know that when we don't have representation, it destabilizes external validity. Everybody knows that you can't generalize if you don't have a representative population. It turns out that you also can't do good science if you don't have a representative population. This is not just an aspirational problem. This is not just a problem of social justice. This is a problem of scientific integrity. When we don't have that representation, we're not doing quality science. And the research is very, very clear across clinical research and by researchers in this room who have demonstrated over the last several years that when we don't have representative data, we have questionable research findings. So all of this really prefaces the Forever study, which was really designed to kind of create a basic science of recruitment, engagement, and retention in ADRD research. The goal is, we don't necessarily have like strong common language, but we also don't have comparative effectiveness. We don't have ontology. We don't have significance tests for recruitment, engagement, and retention. We just have words and aspirations and promises that are very easily broken just 3 years after someone was murdered. The sub-goals of the Forever study are threefold. Number one, I wanted to understand what research awareness looks like in lay communities. Number two, I wanted to understand what RER culture looks like within centers of excellence. I mostly focused on the Alzheimer's disease research centers and the resource centers for minority aging research, the ADRCs and the RICMARs. And then finally, I wanted to talk and understand a little bit more about what that sustainable communications framework would look like between lay and research communities. Now, what's really interesting, what I think this audience does not appreciate, is that this work is being done at a higher level and a more innovative level in the world of Alzheimer's disease and related dementias than any other disease area. I have the good fortune of working across many areas of research beyond Alzheimer's disease. I'm sort of the prodigal son who kind of wandered away and came back to Alzheimer's disease after a few years. And what we see is that we have had significant innovations over the decades from other disease areas, specifically cancer, infectious disease, HIV. But the way that we are thinking about it is that with sophistication and with clear, I think, orientations towards precision and personalized medicine, as we're going to hear about when we talk about social determinants of health later today, this work is really hitting a critical stride purely within ADRD. And there are very clear theoretic disease-driven reasons for why this might be happening. Number one is the way that we are shifting our focus from tertiary kind of treatment to secondary and even primary prevention. We recognize that we can't get the same populations from our clinic environments as we used to. We need larger studies to chase smaller effect sizes. We need individuals who are asymptomatic or pre-symptomatic. So there is a clear motivation that, again, not just for reasons for social justice and aspiration, but in terms of trying to chase like a really comprehensive, clear theory of the disease, that mean that the work that we're doing, the people in this room today, and the ones of you who are maybe paying attention, maybe kind of checking YouTube while I'm talking online, we are the leaders, not just for ADRD, but for clinical research. So stay vigilant, stay motivated in this space. Now, briefly, there are three parts of the Forever Study. Part one is I wanted to go to the community. We've already heard some really great comments on it. So instead of going to 1 or 2 people, I went to 18,000 people. The goal is to break the NIH enrollment table, which I'm planning on doing. Okay, so we are in the middle of data collection. I collected the first 5,000 individuals from one of the most diverse communities in the United States, which is Houston in Harris County, Texas. And then what we are also doing is we're partnering with Qualtrics to deliver the language in 3 languages, English, Spanish, and simplified Chinese. What's critical here is intersectionality. We have a minimum N of 150 individuals at each cell here. There's obviously going to be a lot more individuals, but we're looking at the intersection of race, gender, ethnicity. We are also going to have very clear representation across the queer spectrum. Again, not really easily reported in the inclusion table. And we are also pioneering a novel recruitment method of relational organizing. It's very similar to other kinds of sampling that were innovated with the infectious diseases, specifically snowball sampling. The key difference is that you map the social network first, and then you sample iteratively and repeatedly from it until you have the representative group that you're looking for. The idea is to recruit across a wide variety of diverse identities, so not just race and ethnicity, but thinking about educational attainment, thinking about household income, and to ultimately develop key geospatial mapping tools and norms, which I'm going to be calling tentatively an almanac, I guess. I came up with that term yesterday, to base this data for national use. The idea is to sort of use the same innovations that we've developed to kind of warp and register brains, but we can now do that with this very detailed repository of information where you can use this norming data set to understand sort of recruitment and engagement needs for your own community. So this will hopefully be available for everyone to use next year. So just just 2 really quick things that I found from this study so far. So again, this is just fixed on the first 5,000 participants, looking just at white and black individuals just to make this very, very easy to understand. We see that race is already a very highly significant predictor across these factors. So the question at the top says, how can a research team best connect with your community to offer a clinical trial? So this relates to things that we already recognize and know, which is that oftentimes we see that our default as Alzheimer's researchers is to offer up a clinical trial through our health providers or through social media opportunities. And we need to recognize that that default, just because it works for us as clinicians and researchers, is not the easiest way to reach minoritized populations. Now, again, what's really interesting here is that we make the blanket assumption that all black people are people of faith, and that the only way that you can reach the black folks is by going into the faith communities. Black people are not a monolith. We do have black people. We do have faith leaders here. But you can see here that in addition to faith events, you can also go out to a local business. Did you know that black people go to businesses? It's in the data. It turns out that there are lots and lots of ways to reach black people because they are people. Imagine that. Now, one more quick finding here, just from looking at this data. Again, very, very high level, very, very simple findings here. This other question, which of the following is most likely to make you trust an Alzheimer's disease research team? So what we see here is a really interesting crossover here between the first and the fourth columns that you see. So the site reputation, those meso-level effects, to borrow Crystal Glover's term, are, again, that's our default as researchers. We go in and we say, I'm from Washington University, I'm from Columbia University, and I have, an opportunity for you. It's really good with the white people. White people love that. Turns out that other folks, they are more interested in studying transparency. So translating this to the real world, instead of walking in and saying, I am a representative from an institution that is that has sort of lauded over time but has oppressed your people, you can say, my name's Jonathan, I've got a study. Let's talk about what we're going to be doing for you. Recognizing that there are study-level effects that act as better incentives than institutional-level sort of qualifiers is a really important way of understanding some of the cultural differences that are present here. So, again, just two little tidbits from that larger study where we're going to have, I said 18,000, it's probably going to be closer to 20 when we're done. But I wanted to talk about some of the work that I've done outside of the world of Alzheimer's disease that builds on Dr. Wilkins, long may she reign, her work on the idea of return of value. So we often talk about barriers to participation, but thinking about those values, thinking about those critical incentives that are really crucial. So we applied the return of value categories that Dr. Wilkins and her team identified back in 2019, where she identified 11 categories. We applied it to the problem of gynecologic oncology clinical trials, the way that they're listed in the public-facing fashion on clinicaltrials.gov. And so according to those 11 categories, the four biggest factors for return of value for black individuals, according to the Wilkins factors, are genetics, lifestyle, ancestry, and payment, remuneration, reimbursement, things like that. So we looked at almost 300 trials over a nearly 30-year period, and what we found is that very few of these trials across time really talked about these key incentives. So again, thinking less about barriers and more about incentives, what we saw is that there was a really increasing trend that reflects sort of the fashion of clinical trials to think about patient-related outcomes. So we see that there was some change over time from the mid-90s to now, but only 1% of the trials across this period offered any information, any return of value on lifestyle risk factors, no trend over time. 0% discussed ancestry or remuneration in this particular group of studies. So we need to think about whether we are also applying the same set of return of value factors in our own clinical trials. Again, in terms of what's listed on ct.gov, which is the public's easiest way to understand what's going on here. So this was work that was published earlier this year with Anne Oluloro and Camille Dahl, and we are actually extending this work into other aspects of gynecological research. But it's a really key factor that when we talk about barriers, it is always in the context of incentives. If we provide sufficient incentives, provide sufficient return of value, people are willing to overlook or overcome a larger set of barriers. Now, thinking about the second phase of the Forever Study, so I talked to you about the kind of the lay community. We're also assessing the research community, and boy, I tell you, I have never seen more scared white people in my life than when I walk into these Alzheimer's disease research centers and ask to talk about diversity. Oh my goodness. All right, there's a lot of fear among you. There's a lot of fear in this room, but let me tell you, it's okay. We are all working to be better. I am not here to judge. We are doing what's called an ethnology study, which is a slight tweak on the concept of ethnography. Ethnology is basically ethnography within a context. And so part of the return of value that we are providing is we're developing an outreach dashboard and a workflow for sites to use. So we have actually worked, we've done 4 site visits so far. We've got another few that we're setting up for later this year and early next year. And it has been just a really, really wonderful time checking out what these different groups are doing. From the oldest ADRCs to the newest AD RICMARs in the country. It's been just a really wonderful opportunity. We are very careful in the way that we set these up. We do 3 pre-planning meetings just to kind of help people feel a little bit more comfortable with why we're there and what our goals are. And so then we do a site visit where we do a facilities tour. We try to learn a little bit about the city and understand what's going on. What I like about this study is we don't just divide it into research community people and lay community people. We really look at nuances within those groups. So any of you who are, have worked for any amount of time within these centers of excellence know that when it comes to thinking about recruitment, engagement, and retention, when it comes to thinking about diversity, let's say the clinical core thinks about it a little bit differently than the OR core. And the biomarker core thinks about it a little bit more differently than the admin core. So it's important to think very carefully and with nuance among these different community members. So we've done about 136 interviews and focus group participants, and we've actually found a number of really interesting findings. I'm not going to try to go through all these quotes here, but there are some really key themes. The theme number 1 is the community are not fools. They know when that engagement is sincere, and they know when it's not, and they won't tell you, but guess what? They will tell me, and they have. Number 2, we know that competition between groups, usually within these centers of excellence, really sets up a lot of both positive but mostly negative experiences within these centers. And so what ends up happening is that there's a lot of kind of intergroup tension and competition that ends up limiting the kind of the expansiveness and sort of the effectiveness of these I think RER initiatives more broadly. 3 other themes that I think are worth highlighting. Lay communities are often looking a little bit more for information and access and timely diagnosis when it comes to Alzheimer's disease and related dementias. So if you kind of stroll in and ask immediately for people to participate, you usually need to do a little bit of kind of partnership and literacy building around what research is, but also understanding what Alzheimer's disease is, how somebody can get a timely diagnosis, how they can manage a disease before you ask for your thing. A couple more things. And we hear this, I think, increasingly often, that one of the major reasons for mistrust is sort of historical, talking about Tuskegee. While that is true, I think most individuals are willing to overcome that particular element of mistrust, so they do mistrust, but they are still willing to engage. What is a more significant driver of that distance that we feel between minoritized community are local perceptions of mistreatment that they experience at the individual or the community level. So it's not Tuskegee that's stopping people in St. Louis from participating, it is the legacy of Barnes-Jewish Hospital and Washington University itself. So we need to keep that in mind, that it is not someone else's problem. It is right here, right now, and that's not just true in St. Louis, it's true all over. And then finally, these institutional and systemic barriers, they really challenge kind of extending this work. This work really happens in a very piecemeal and siloed way, which is unfortunate because it ultimately limits the overall impact. Very quickly, because I know I'm running low on time, a sub-study that really fell out of this, that was not an intentional part, is thinking about the intersectionally marginalized individuals. So diversity is great, inclusion is great, but universal design is better. So powering our research, especially in ADRD, for the most marginalized individuals is the best way to go. So working with Chastity Bowick, who is my research center's director of community engagement and a trans woman, we've designed for thinking very carefully about trans women of color in the ADRD space, which is a very interesting prospect for a few reasons. Number 1, addressing intersectional discrimination experienced by trans women of color will resolve barriers for everyone. It's just true. But beyond that, this is an emergent group of critical theoretical relevance to AD itself. So number 1, this is a group that is only recently really starting to think about diseases of aging. mainly because they've been killed in their 30s for much of history. But also, more relevantly, trans women of color specifically take hormone replacement therapy for decades, which we know has an outsized impact on dementia risk. So this is a group that is worth studying in terms of understanding the disease, the disease of Alzheimer's itself. So we've done 2 site studies. We've got another one in Ohio next week. We have a sample size of 53. What I want to note here is that sample size of 53 trans women of color is already one of the single largest studies in history of trans women of color, not just for ADRD, but for any clinical research topic ever. 53. And we did this by accident. Imagine what we could do in this room with intention for this particular community. Now, we've got diversity within this groups, but what was really remarkable about this particular sub-study is that there are stages prior to what we think about when it comes to recruitment, engagement, and retention. There are phases of being multiply vetted, and what's really interesting is that those phases of multiple vetting is not just peculiar to the trans women of color, it's the same set of multiple vetting that I myself have faced when I'm trying to come into your centers to do this work. So once again, powering for the intersectionally marginalized helps us understand what's going on in a much larger level. Now, I know that I'm running low on time, so I'm going to, instead of kind of going through the rest of these findings, I just want to end on just a couple of words of warning. There is a clear culture of opacity and scarcity that is invented when it comes to the study of recruitment, engagement, and retention. There's a lot of fear and resentment that have overwhelmed us, that have limited the impact of this work, and that may continue to derail even the work that I'm doing, that I'm talking to you about today. Late communities are left behind in our echo chamber. We can pat ourselves on the back in this room all we want, but mostly the communities that we claim to care about are left behind. We've already seen a couple of clear examples of that this morning. Most importantly, the Hawthorne effect, which reflects social desirability, and white feminism are now the most pernicious factors that we see here. Everybody's on board that this is a problem, but how we resolve the problem, thinking a little bit more about intentions than impact is one of the hallmark symptoms of white feminism. Thinking about individuals who can speak both as an individual and then present themselves as sort of avatars of a larger system, and they get to choose when they have which of those hats they wear is another hallmark symptom of white feminism. And these are the things that make it very difficult to build true systems of kind of accountability around this particular issue. So in short, I'm going to stop here and say, diversity isn't more complicated than neurodegeneration. I don't know why we keep pretending that that's the case. If we can achieve research diversity in terms of APOE representation, if we can make significant progress in just the last 15 years on one of the most pernicious diseases of aging that we know, then we can solve this problem. We, again, in this room, are the most sort of research-forward group, potentially in the world, studying this topic. We can solve this today in this room if we wanted to. So I just want to encourage everybody, and I'm going to stop here, to kind of keep in mind the words of another, I think, significant historical activist, MC Hammer. When you're measuring, make sure that you include the measure. Thank you.